It's time for another warm-up review. Let's get going. First one here, which bacterium is an obligate anaerobe, gram-positive, spore-forming rod? So think of Clostridium species. Next, why are aminoglycosides ineffective against gram-positive anaerobes? Well, aminoglycosides are ineffective against gram-positive anaerobes because they are antibiotics that require oxygen to enter into the bacterial wall. Remember that you use O2 and amine O2 glycosides. That's one way to remember that. And that helps you to get to that point. Now, aminoglycosides are commonly given for gram-negative infections, but what do we use for anaerobes? Remember, we use things like metronidazole and clindamycin. Next, damage to which part of the basal ganglia causes hypokinesia? So this is the substantia nigra pars compacta, which can be affected in Parkinson's disease. All right, that's it for the review. Let's get to the video.
In this video, we're going to talk about some electrolyte disorders because the kidneys are integral to maintaining balance of things like sodium and potassium and calcium in the serum and in the interstitial fluid. Now, one of the ways that the kidney maintains homeostasis of these electrolytes is through hormones. We don't often think about it, but the kidney is actually a very important endocrine gland. For example, the JG cells, the juxtaglomerular cells in the kidney, make renin when they're stimulated by one of three things: epinephrine acting on the beta-1 receptors, perceived low blood pressure in the afferent arterioles, or low sodium in the distal tubule as sensed by the macula densa. So again, that ties directly into sodium balance. Then in terms of maintaining calcium balance, the kidneys help to convert vitamin D to its active form. So the skin makes vitamin D with the help of UV light, and then the liver adds a hydroxyl group, so you have 25-hydroxy vitamin D, and then the kidneys have an enzyme called 1-alpha hydroxylase that adds a second hydroxyl group to make 1,25-hydroxy vitamin D, and that's the active form. And that's facilitated by PTH. So if there's a lot of PTH, a parathyroid hormone, around, you'd have more vitamin D around. And the main thing that vitamin D does is increase the intestinal absorption of both calcium and phosphate. When we get to hematology, we'll talk about how the kidneys make a hormone called erythropoietin, which stimulates the bone marrow to make more red blood cells. So with kidney disease and kidney failure, erythropoietin levels are low, and these patients will be commonly very anemic. So we often give shots of erythropoietin to kidney failure patients. And then the kidneys also make prostaglandins, which dilate those afferent arterioles and increase GFR and increase renal plasma flow. This is actually a paracrine function because it's happening locally rather than sending this hormone off to some distant site in the body. And we talked about how NSAIDs can reduce prostaglandin production and therefore reduce GFR. Now, those are the hormones that are produced by the kidney. What about hormones that affect the kidney? Well, I just mentioned how PTH stimulates the kidney to activate vitamin D. PTH also stimulates the kidneys to increase reabsorption of calcium and to decrease reabsorption of phosphate so that serum phosphates go down. Remember, we said PTH is phosphate trashing hormone. We've also talked about the renin-angiotensin-aldosterone system several times already, so that's how hormones affect the kidney. Another hormone we've mentioned before is atrial natriuretic peptide, which is released by the atria of the heart in response to increased atrial volume and increased atrial pressure. So if the heart perceives that the atrial pressure is too high, it can send a hormone signal to the glomerulus to constrict the efferent arterioles and dilate the afferent arterioles. And that's going to increase GFR, and that's going to lead to diuresis. So ANP does the opposite of aldosterone. Instead of retaining fluid and expanding the intravascular volume and raising the blood pressure, ANP causes diuresis and helps to reduce the blood pressure a little bit when the atria become overfull. The kidneys also respond to vasopressin, which is also called antidiuretic hormone, or ADH. And we've seen how ADH permits the collecting tubules to reabsorb water and therefore concentrate the urine. Remember, antidiuretic hormone causes anti-diuresis, which means you're retaining water and you're concentrating the urine. Next, let's talk about two disorders that are both related to ADH. First, we'll talk about the syndrome of inappropriate ADH, or SI-ADH, where you have too much ADH. Then later we'll talk about a deficiency of ADH, which is diabetes insipidus. So SI-ADH means you have too much ADH. So you're reabsorbing too much free water and you're excessively concentrating the urine. So these patients have very concentrated urine and very dilute serum. They have low serum osmolality and low serum sodium. That's why we're talking about it here. SIADH is a very common cause of low sodium. So what causes SIADH? Where's all this ADH coming from? Well, ectopic ADH production from a small cell lung cancer can do it. That's a paraneoplastic syndrome. Really, any pulmonary pathology can cause SIADH. COPD, pneumonia, anything in the lung. Then also, anything in the head can cause SIADH. So head trauma, stroke, CNS infections, anything going on in the head. Sometimes drugs can cause it, especially the immunosuppressant cyclophosphamide. But you're going to see lots of people with low sodium and SIADH. You're not going to see lots of people on cyclophosphamide. And then plenty of times you won't identify a specific cause. It's just idiopathic SIADH. Now, if you correct hyponatremia too quickly, you might cause lysis of the myelin in the pons, which is called central pontine myelinolysis. That's one of the causes of the locked-in syndrome, where the patient's conscious, but they can't move anything, they can't communicate. So it's a pretty devastating complication. Then the opposite of too much ADH would be too little ADH, which is a problem in diabetes insipidus, or DI. So what does this look like clinically? Well, ADH helps you reabsorb water in the collecting tubules so that you concentrate the urine and you produce less urine. So without ADH, you can't concentrate the urine. You're going to have increased urine volume, and the urine is going to be very dilute. And this is going to cause a highly concentrated serum as a consequence. So serum osmolarity is high, but the urine-specific gravity is low. And there are two flavors of DI. There's central DI, where the hypothalamus isn't producing ADH normally. If the hypothalamus isn't making any ADH, we call that complete central DI. But more commonly, the hypothalamus makes just a little bit of ADH, just not enough. So we call that partial central DI. So central DI is one big category of DI, and the other category is nephrogenic DI, where the kidneys have become unresponsive to ADH. So in nephrogenic DI, the hypothalamus is making ADH normally, but the kidneys just can't respond to it. So what would make the kidneys stop responding to ADH? Lithium is one thing. We've seen this diagram elsewhere, and it keeps coming back to haunt us. This is the mechanism by which lithium causes diabetes insipidus, and it's worth knowing. Remember, ADH causes the principal cell in the collecting tubule to insert these aquaporin water channels into the luminal side of the cell so that water will be reabsorbed. But lithium interferes with that process. So lithium is one drug that can cause nephrogenic DI. Another drug is dimeclocycline, which is a cousin of tetracycline. Dimeclocycline also interferes with the action of ADH, so sometimes we use it off-label to treat chronic SIADH because you're blocking the action of ADH. I don't know if I've ever seen dimeclocycline used as an antibiotic, but I have seen it used for SIADH. But because it prevents the kidneys from responding to ADH, it can cause nephrogenic DI. Hypercalcemia can potentially cause some nephrogenic DI as well. And there's also a hereditary form where you simply have a mutation in the gene for the ADH receptor. For step one, you need to be able to interpret lab results and recognize what type of diabetes insipidus a patient has. So say you have a patient who presents with excessive thirst and polyuria. Well, the first thing you'll probably think about is diabetes mellitus, which you can easily rule out by checking the urine for glucose and checking the serum glucose. But say that's normal. The next thing you would test is urine and serum osmolality. And what do you expect those labs to show in diabetes insipidus? Well, the patient is losing free water in the urine, so the urine osmolality is low and the serum osmolality is high. Then the next test you do to confirm the diagnosis is called a water deprivation test. So this is where you restrict the patient from drinking water and then you recheck the urine osmolality. Now in a healthy patient, the patient is going to get slightly dehydrated when you water restrict them, and they'll secrete ADH and start concentrating the urine. So if the urine osmolality rises after water deprivation, that's a normal result. But a patient with diabetes insipidus can't concentrate the urine, so the urine osmolality will stay low. That tells you this patient definitely has diabetes insipidus. Then how do you distinguish between central diabetes insipidus and nephrogenic diabetes insipidus? Well, you need to do a test called a desmopressin challenge, where you give the patient an ADH analog called desmopressin. Now, if you give desmopressin to a patient with central diabetes insipidus, the urine osmolality will finally rise because you've corrected the patient's ADH deficiency. And technically, that urine osmolality has to rise by at least 50% to be considered positive for central DI. But if you give desmopressin to a patient with nephrogenic DI, that patient already has plenty of ADH circulating, but the kidneys can't respond to it, right? So if you give desmopressin to a patient with nephrogenic DI, the urine osmolality will not change, or it might rise very slightly, but less than 50%. So how do we treat diabetes insipidus? Well, if it's central DI, then the treatment would be intranasal desmopressin. You're just replacing the hormone that's deficient. For nephrogenic diabetes insipidus, it's a little trickier. First-line treatment is hydrochlorothiazide, or HCTZ, which doesn't automatically make sense. They've got DI, so they're peeing too much, and now you're giving a diuretic to make them pee more? Well, the deal is that the hydrochlorothiazide causes the patient to become a little bit dehydrated. And that means that back in the proximal tubule, the workhorse, where most of the reabsorption takes place, the kidney is going to reabsorb more water, so that by the time the urine gets to the collecting tubule, it's already a little bit more concentrated. Remember, the proximal tubule and the loop of Henle tend to concentrate the urine, and the distal tubule dilutes it. Then the collecting tubule is supposed to concentrate it again. So HCTZ is basically preventing the distal tubule from diluting the urine. So HCTZ is first-line treatment for nephrogenic DI. Second line would be indomethacin, which can also be used in addition to HCTZ. Indomethacin will inhibit prostaglandin synthesis and reduce renal blood flow, and that's going to decrease urine output somewhat. And then if you're treating lithium-induced nephrogenic diabetes insipidus, the potassium-sparing diuretic amiloride is also particularly helpful. Amiloride blocks the sodium channels that lithium uses to enter the principal cell. So sometimes when you have a bipolar patient who really needs lithium, but he's getting diabetes insipidus from it, you can add some amiloride and that'll allow the patient to stay on lithium. I mentioned that SIADH is a common cause of low serum sodium or hyponatremia. So let's briefly talk about some of the important signs and symptoms associated with electrolyte disorders. This is very, very testable. So they might give you a clinical scenario and show you an EKG and expect you to recognize that there's hyperkalemia, for example. So let's look at some high-yield electrolyte disorders. First of all, hyponatremia or low sodium can cause confusion and altered mental status, especially in the elderly. It can also lead to seizures, it can lead to stupor and coma. Now, that's pretty nonspecific, but just be aware that when the electrolytes get out of whack, it messes with the resting potential of neurons, and that causes CNS problems. Another disorder that classically will cause some confusion is hypercalcemia. Now, in endocrine, we have a whole video on calcium metabolism. Dr. Cox is going to discuss all the clinical manifestations of hypercalcemia, which includes stones, bones, abdominal groans, and psychiatric overtones. So those psychiatric overtones can include pretty serious confusion and delirium. These patients can get crazy weird. Then with low calcium or hypocalcemia, you need to remember tetany, which we test for with Trousseau sign. Remember T for Trousseau and T for tighten the cuff, tighten the blood pressure cuff on the arm, and causes carpopedal spasm. And you can also test for Schwastek signs, so CH for cheek and CH for Schwastek. You're tapping on the cheek and tapping on the facial nerve and getting facial nerve spasm. And then hypomagnesemia or low magnesium will also cause tetany. And then hypermagnesemia or high magnesium will depress the reflexes. So if you give IV magnesium to a pregnant mom who's in preterm labor, you're giving it to try to suppress muscle contractions and stop the labor. But if you give too much, you'll cause hyporeflexia. So if we're giving a magnesium drip, we're going to do serial neuro exams, and if the DTRs go from 2+ down to 1+, you know you need to stop the magnesium for a little while. You're getting a little too much magnesium. Then going back to hypomagnesemia or low magnesium, that can also cause EKG abnormalities and arrhythmias. So low magnesium causes a wide QRS complex and could cause torsade de pointe, which is a form of V-tach, where the V-tach has variable amplitude. So it gets bigger and then it gets smaller, bigger and smaller. It's pretty easy to recognize. And speaking of V-tach, I want you to remember that low magnesium and low potassium tend to go together. So hypokalemia can prolong the QT interval and lead to V-tach and torsades just like low magnesium can. And actually, hyperkalemia can also lead to V-tach. Potassium's kind of like Goldilocks. It's got to be just right or you can get into trouble quick, whether it's too low or too high. But the classic EKG findings I want you to remember with hyper and hypokalemia are that the T waves tend to mirror the potassium levels. So if the potassium's high, T waves are going to be high. They're going to be tall and peaked. We say the T waves look sharp, like you wouldn't want to sit on them. They're sharp and pointy. But if the potassium is low, then the T waves are somewhat flattened. And if the potassium is really, really low, you might see a prominent U wave, which is a wave that comes after the T wave. Now, while we're talking about potassium, let's look at number 4 in your study guide and talk about potassium shifts. Like I said, serum potassium needs to be just right. So serum is relatively low in potassium, but the intracellular fluid is relatively high in potassium. So what kinds of things shift potassium outside of the cells, and that's going to cause hyperkalemia and potentially affect the heart? Well, low insulin can do it. So diabetic patients might be more prone to have hyperkalemia, especially if they're in DKA because they have low insulin. Beta blockers can shift potassium out of cells. Acidosis can also do it. Remember, with acidosis, your cells are trying to correct the acidosis by moving all those excess hydrogen ions out of the blood. They're trying to raise the pH and get rid of that hydrogen ion in the blood. So the mechanism they use to accomplish this is to exchange hydrogen ions for potassium ions. And that results in pumping too much potassium out of the cells into the blood. So acidosis can lead to hyperkalemia. Then digoxin can shift potassium out of cells. And then cellular lysis can do it as well. If your cells die and they rupture, they're going to leak all that potassium into the interstitium and into the blood. Then what kinds of things shift potassium into the cells? Well, it's just the opposite. Insulin, beta agonists, alkalosis, and cell creation or cell proliferation, like with cancer. Now, why is this clinically relevant? Well, let's say on your exam they give you this EKG and they ask you what intervention would correct this finding. Well, what does this EKG show? Tall, peaked T waves. And what electrolyte abnormality does that suggest? Hyperkalemia. That is what you said, right? Speak up next time. So if you see tall, peaked T waves, you're going to think about hyperkalemia. And then you need to know how to treat it before the patient goes into VTAC and cardiac arrest. So you need to figure out a way to shift potassium back into the cells as quickly as possible. So one thing you could do to help correct this hyperkalemia acutely is to give them a beta agonist like albuterol. You give them some nebulized albuterol and that's going to start to shift potassium into the cells. Alkalosis would help too, so you could give IV bicarb as well. You can also give some insulin, especially IV insulin. The only caveat here is that insulin is going to lower the blood sugar rapidly, so we give IV dextrose and then give the insulin to make sure that the glucose doesn't bottom out. So 3 emergency treatments that are helpful to correct hyperkalemia are a beta agonist like albuterol, IV bicarbonate, and IV insulin plus dextrose or D50. But you also need to know that the first treatment for serious hyperkalemia with EKG changes is to give IV calcium to stabilize the myocardium and to prevent arrhythmias like VTAC. Now, calcium will not shift potassium into the cells, so it won't correct the hyperkalemia, but it does prevent arrhythmias. So the first treatment for severe hyperkalemia is to give IV calcium. Now, that brings us to the end of session quiz. So pause the video, work through those questions, and then we'll go through the answers together. First question, which electrolyte disturbance fits each of the following presentations? Correcting too rapidly may result in central pontine myelinolysis, is hyponatremia. Peaked T waves is hyperkalemia. Tetany would be seen with hypocalcemia and also hypomagnesemia. Arrhythmias could be hyperkalemia, could be hypokalemia, or could be hypomagnesemia. Decreased deep tendon reflexes are seen with hypermagnesemia. And then flattened T waves with U waves on EKG would be hypokalemia. Next, what are the diagnostic features of diabetes insipidus? Well, the patient's going to have polyuria, and the urine is going to be dilute, so you have low specific gravity and low urine osmolality. Then on water deprivation test, if the urine osmolarity does not rise with water deprivation, that's diagnostic for diabetes insipidus. Then you're going to distinguish between central and nephrogenic DI by giving desmopressin. So if you give desmopressin and the urine osmolarity rises, this points towards central DI. But if the urine osmolarity does not rise, this points toward nephrogenic DI. Next, what factors or substances cause hyperkalemia? So we talked about things that shift potassium out of cells. Acidosis, insulin deficiency, beta-adrenergic antagonists, digoxin, and cellular lysis. But I also want to throw in potassium-sparing diuretics and ACE inhibitors. Now, those don't cause potassium to shift out of the cells, but they can cause hyperkalemia. And then the next question, what factors or substances cause hypokalemia? Again, the things that shift potassium into cells are insulin, beta-agonists, alkalosis, and potentially cell proliferation. Then we can add loop diuretics and thiazides as potential causes of hypokalemia because they cause the patient to dump a lot of potassium into the urine. So that's it for the end of the session quiz. And now we have 3 rapid-fire facts. So the treatment for central DI, again, it's desmopressin. The treatment for nephrogenic DI is hydrochlorothiazide or HCTZ, indomethacin, and possibly amiloride. And the treatment for lithium-induced nephrogenic DI is amiloride. All right, see you next time.